convert this into a preventive part rather than, doing a curative part. I bring greetings from Mumbai, and I love to start my deliberation with a wonderful statement of William Golding stating that I think women are foolish to pretend they're equal to men. They have been far superior and always have been. This is the truth with our patients as well. And that's an important reason why we are putting a lot of stress in talking about a preventive part and screening. We do not want to lose our women into, having cancers and then those pathetic movements. So the objective of screening is to identify it at the earliest and then treat it where it becomes very easy. And now understanding that in India, the estimate of initially is the breast cancer and then is the cervix and ovary and then later on all the other things. Now talking about, for me, Kunni Mohiddin has given me a very tough topic. In fact, he has given me a vast topic, to be covered in 15 to 20 minutes. I'll try to do my best to finish it in this time. Because I'm going to talk about cervix, I'm going to talk about ovaries as well as endometrium. Now, cervix, it's very close to my heart, preventive oncology, and that especially for cervix. And because 1 out of 4 women dying out of cervical cancer is an Indian. And what's more pathetic and what's more alarming is this figure where you have now it is reduced. You can see now because of all the efforts put by many of these stalwarts, whatever was the figure more, now that's come out to 60,078 deaths annually. And but still what's alarming is 1 death due to cervical cancer every 9 minutes and daily 200 women dying due to cervical cancer. Now, from 10 o'clock to this 1:32, we have been sitting over here. Imagine how many deaths due to cervical cancer. We've been talking about COVID and we're talking about so many deaths. But this is the fact. And then we all know the risk factors is nothing new to all these stalwarts sitting over here and the senior gynecologists taking part in this excellent virtual conference. The risk factors, basically what is more alarming and where we have to stress ourselves is this persistent high-risk HPV infection. Because the persistent oncogenic HPV infection is the necessary cause for the cervical cancer, and as stated by Harald Hussein, for which he won the Nobel Prize in 2008. Talking about an HPV, now this is a cumulative risk of acquiring HPV in about 80% of the women, and they are quite silent. I mean, it comes and it goes. We do not know about it. And the spectrum of HPV goes from condyloma acuminata to cervical dysplasias to cancers. And knowing the fact that there are 150 different types of strains, we do have 1618 as the most prevalent strain in our country, which is responsible for 80% of cancer, cervical cancer, squamous, as well as adeno. And for that, we have definitely a primary prevention with HPV vaccine. Now, talking about these of what we actually see in a cervical cancer and where we land up as a preventive oncologist. And I think all the gynecologists are preventive oncologists. There need not be a separate branch, of a preventive onco, because we all are dealing. I mean, there's nothing new to put it into an asterisk. So the main thing is because when the patient comes to us, we do have initially with the, with this, where we do not, she hasn't had her sexual debut or she hasn't had any, of the infection as such. Then HPV, where we can definitely have this with the prevention part with vaccination. And after the sexual debut, it might be she has contracted an HPV. And if it is persisted, we have the spectrum of, mild to moderate to severe precancerous conditions. This is where exactly we play a role so that we prevent, we treat, if we identify this. We identify with certain parameters. And this is hidden, absolutely hidden, unless and until you really do certain things, we will not be able to find this out. We have 10 to 15 years when this stage goes, and we do not want our patient to go here. So that's how we identify the cervical precancerous conditions in various stages and then treat it. Now, suppose if you do not treat it, what's going to happen? Let's understand this. That's exactly what we have been doing. We weren't much into screening. We weren't much into identifying unless and until it's something like the patient really comes, and then you think about it. Okay, why not? But what happens in a case of a natural history? This is a beautiful paper of 30,000 women who were, a natural course was found for them with the Austin et al. And he found that, CIN1 regresses 57%, nevertheless, but 1% progresses to invasion. And high lesions like SIN2, SIN3 definitely has more chances of progression to lesion, and that's invasion, and that's exactly where we identify them, we treat them, and then that's how WHO has put a position paper stating that cervical cancer is the only cancer where it is prevent. So prevent the preventable is the mission now. And then we have a different type of services coming to us daily and day out. And we are trying to understand what is going wrong with the cervix. I mean, that's how we then come to identify what do we do with it then. So we have, these were at least symptomatic people who came to you with unhealthy cervix. But imagine people who are not symptomatic, who do not walk into your clinic with this thing. And they are the people where you have to catch them and we have to screen them. And we have all these methodologies. And then the importance of screening is actually it's done for a symptomless population. And then you are, with the precancerous conditions found out, we treat it adequately. Now we have different modules of and tools when you talk about screening. Now, low resource setting, VIA, VILI, high resource setting, where people do have money to pay, because unfortunately in our country, government, it's not come up into insurance like it is abroad. And when it's not come into the insurance, people have to pay from their pocket, and then this becomes a little bit, more burning of their pocket, and they do not actually have any disease. That's something which you'll have to understand. The screening is done for a population which apparently appears asymptomatic. So then you have HPV DNA cytology, you triage them, and then you find out certain diagnostically with colposcopy, or you do a code test, or you have even very high resource setting, with genotyping and all that. But there is a paradigm shift. We have been always talking about PAP test, 1953, so we have been talking about PAP test in our country. And yet we haven't seen a drastic change. Okay, there is a trickle change, a trickle reduction, but still there is a lot of work to be done. So we have now started focusing on VIA as a better parameter, because PAP again goes with an observation specific, and then you have colpo, histo, LBC, and then you have all these HPVs. Now, talking about the understanding of different methodologies, what we use is a VIA, the sensitivity of, cutoff. If you have a SIN2, your sensitivity is 79%, specificity is 85% to identify SIN2, and VIA has a sensitivity of 83% to identify SIN3 with specificity of 84. It increases if you add up villi. PAP has got a lowest sensitivity, even if you put a cutoff of ASCUS, and the specificity is, of course, very high. And HC2 has a wonderful, it's a sensitivity of SIN2 and specificity of SIN3, sensitivity of 62%. So to put it in a nutshell, it is in this way. Now we're talking about a PAP. I'm just going to tell you, because we have been doing PAP, and we have been right from our childhood days of UG in a medical colleges till date, we have been knowing about PAP. We have been because as a master trainer, I have traveled across the country, and knowing the actual crux of what's happening at the grassroots level, most of them have been into conventional PAP. With still the slides are being used, and fixations are being done. Vis-a-vis to that, we have a liquid-based cytology, which is definitely going to improve the picture. With this endocervical brush, we're supposed to scrape through the SC, the transformation zone. And if you look at this, the video of how a cervical scrape is being taken, it's taken with nice, you turn it clockwise or anti-clockwise, whichever is convenient to you, and you pick up the scrape from SCK. And then you can drop the whole thing inside. You have a vortex, then you fix, and this is how LBC technique is being done. You have dispersion, your cellular connections, and again, then you are to transfer it. So when you transfer it onto the slide, you have a clear picture. You can see over here, the cells are quite visible, and vis-a-vis to a conventional where you have a lot of leukocytes, inflammatory smear, and a lot of RBCs, And then whenever you are talking about PAP, it's not only the cells, it's also about the infection. That's how a Bethesda is being point, and then you have the trichomoniosis, candidiasis, bacterial vaginosis, and all that thing. And of course, endometrial cells in the postmenopausal age group also does have a lot of role in the Bethesda classification. And then you have this type of understanding of the cells on an LBC. When many time I've been asked this question, ma'am, what's better, LBC or PAP? And I always say them that it increases the sensitivity of 12% when you have to identify low-grade squamous intraepithelial lesions, that's LSIL, but doesn't have any much of a difference in specificity, So do not feel bogged down that you don't have an LBC in your place or whatever, the region, wherever you're practicing. It's still better if you're really collecting it in a proper manner. And then many a times, this is the cloud which roams, which floats onto our head every time, inflammatory smear. What am I to do with it? And then there is the patient walking from one doctor to another. So now the answer is an HPV, and an HPV with a lot of strains, you have low risk and you have high risk. And approximately 50% of the sexually active women will be having genital HPV sometime or the lifetime, And you have now the understanding of it. I'm not sitting over here to teach. I'm actually getting through, and generally touching each point and going. Only thing which I like to stress over here is there are multiple commercial labs coming up telling that we have HPV, we are offering you HPV with a low rate. Do not fall into the jargon of the low rates, vicious cycle of low rates. You have to understand that HPV, which is the methodologies are PCR, which is an RT-PCR also, which is being used. Hybrid capture is the most important primary, screening tool with a hybridization method. Now, these are what has been approved by WHO and globally approved. Even our GCPR has approved that hybrid capture. Now, we do not have Servista with us. We do not have Actima with us. But of course, Cobas 4800 with Roche Molecular Diagnostics, we have with us. So this is an ISCP guidelines, and I'll be talking much on GCPR guidelines, which we have formulated for our country. This is an American guidelines. Now, if you have to talk about the FOXY GCPR, and we have 3 charts, we can do it primarily with a HPV test or a core test or with VIA. Let's first talk about primary HPV test. If you're doing an HPV test, if that's coming positive, you have triaging methods with VIA, with cytology, or with genotype. If you do with an genotype, I usually love to do this because you have 16, 18, then you go directly for colposcopy. Now, if I do not have this, offering, I do not have in my lab or something of that sort, or the patient is not ready for it, then I have a cytology where, if it is more than ascus, you go for a colposcopy. It is NILM, just repeat the sample. So what's happening is, whenever a patient is coming with HPV, she immediately Googles, her Google-friendly guru tells, HPV means cancer. That's something which we will have to eradicate because, of course, HPV relates, but then we'll have to understand an HPV is it's an infection which washes away also. So you will have to give a good counseling to the patient, stating that an HPV, we will have to repeat it. Only if the repeat is a persistence, then it leads to cancer. If she is really scared, you go for a VI, otherwise find better what is the morphology and do a colposcopy if it is, it's available with you. Otherwise, if you do a core test, like I am in, I always, in Mumbai and in Delhi where I practice both areas, I love to do this core test, and then that gives you a good sensitivity and a good specificity to go about with it. If you're doing with a genotype, and this is exactly what a Cobas 4800 has brought to you, the screening guidelines, that if you're doing with a primary HPV screening and you're using that, then if it is 16-18, you go for a colposcopy. If it is non-16-18 positive, you do a cytology. If it is more than ascus, go for a colposcopy. Otherwise, if it is NILM, just repeat it, nothing to worry. And if it is negative, then routine screening. Now, if you go for a low resource setting, and that's with VI and VILI, which is the government guidelines is also talking about VIA that you started with 30 years, every 5 years till 65 years. And if we are able to adopt this in our clinical practice, routine clinical practice, you do not have a colposcope, nothing to be be done. Just take up a fresh VIA and make it up like 5%. It can be done with 1.5 ml or 9 plus 9 ml of the distilled water, or 1 ml of glacial acetic acid to 19 ml of distilled water, and then make it fresh. Apply it. You can see VIA negatives. This is certain VIA positives. These are all, I have done it in my OPD, taken up on an Android phone. This is all the teaching tools also which we have developed for Government of India through my master training courses in MP Maharashtra, which they have also accepted also. So you can see over here VIA positives, and to increase the sensitivity, you have villi, that is Lugols. These are the Lugols positives. So you can see over here that villi is completely negative. What is villi negative? You can see all the mahogany brown. This actually has whatever is the stratified squamous epithelium has a glycogen, and that's how it is becoming negative. So they take up Lugols. And these are villi positives cases. So whenever you have when you're going a screening with VIA, you preferably you do it till 50 years, because it is a TZ3. Beyond that, if we all know about the physiology, so the preferably 30 to 65. But if it is a TZ3, VIA doesn't have much of a benefit, because it can be a endocervical and we might miss out. So if it is a positive, you can either do a screen and treat if all the thing fits into the criteria. Do a screen and treat. You have an ablation. Otherwise, if you want to get it more evaluated, do a see and treat. Send it to a colposcopy unit. Get it evaluated and treat it accordingly. If it is normal, you can return it after 5 years. So now, once you find that the third eye of Shiva, similarly, colposcopy is the third eye of a gynecologist. And then with a biopsy, colposcopy, rooted biopsy, guided biopsy, it is a gold standard. And these are the indications that we all know about the steps of colposcopy: normal saline, green filter, 5% acetic acid. If there is an acetovite area because of high coagulation, then you have to identify with Lugols. Again, the fourth step, and then that's how you identify. I'm not taking you through this is the procedure of a colposcopy. I'm just quickly taking you through it. 1 minute of application of acetic acid, 1 minute of observation. And when you do this 1 minute of observation, you might get a similar type of acetovite areas coming up, developments. And these developments, and what is a negative, VIA physiological positives are metaplasia. So a colposcopy should understand what is physiological and what is pathological. Pathological VIA positives come from SCJ within the transformation zone. It's coarse, it's opaque, it's, the margins are well defined. And once you do that, you apply a Lugols, and then again with the Lugols, you will see the areas which were lesion areas becoming villi positives. And once you identify the lesions, you are supposed to take a punch biopsy, and that too, that you do not require any anesthesia for it. That's again something which we will have to tell our gynecologists. Do not worry, do not fear that, see, there's a nice punch taken up, it doesn't take. You can just put an Monsel paste, or you can just put a little pressure, and that's done. So these are the lesions which you have found out on a colposcopy. You have a suite techniques to score it up, to identify, and that's how the lesions are being found. And once treated, you have to, once identified, you treat, okay, with ablative and excision. So this is all about cervix, and now I go with ovarian. Now, ovarian is 3 to 4% of all the women will have, this is the prevalence in the epidemiology, and the third most common deaths. Now, talking about in Indian strategy, we have the highest incidence in Delhi and Pune registries. And this is most commonly seen at the peak years of 55 to 65. And now talking about the familial history, the familial transmitted site-specific ovarian cancer syndromes are, if it is only ovary or ovaries, it is 10 to 15%. If it is related with breast-rich HBOC, with BRCA1 and BRCA2 gene involvement, it is 65 to 75% for hereditary ovarian cancer. And if it is a non-polyposis, colorectal involved, that is HNPC syndrome, you have other areas also involved like colon, endometrial. Talking about age factor, we know that this is more common in postmenopausal status with an obesity, high nulliparous, late first child, involuntary infertility, HRT, and so lifestyle associated And the early warning sign, the basic thing is it's very symptomless. We always see it in a later stage. That's the main this thing about it, specific thing. And you might have a slight bloating. It might be just an indigestion, dyspepsia, and you might not know. And you put your hands on, and when you examine her, you might find a tumor rising out. So something of that sort. So healing quickly, feeling full, and then see all that thing. So abdominal examination, you would find a flank fullness. Also, sometimes if there's an ascites, lymph node can be supraclavicular or inguinal areas can be enlarged. And physical examination, benign mass, malignant mass, we all know about it. Now, when I'm coming to the screening, so that's very important for we gynecologists to know when to start the screening and what are the, because ovarian screening is a little ambiguous with a lot of gray zones, vis-a-vis to the cervical screening. Cervical screening has a clear-cut parameters, whereas in this, you have many parameters. Let's touch and go a little bit of them. Talking about, we are very, very, very familiar with CA-125. Many of us have been using this more than or equal to 30 units per ml. It has been taken up as a risk estimated factor. Now, is this alone sufficient? This is something which we have to ask because there are limitations. It is raised also in several other conditions. Also, it is to be noted that in physiological conditions also it is raised. And also to that, in the early stages, it is not raised to that level. It's only 50% raised. So we miss out our early stage, this thing. And in the case of postmenopausal women, we might have a false positive high rates as well. So the limitations are all these. It is less sensitive in detecting patients with early ovarian cancers. And when we talk about this, we have that because this is a good question, position papers, it has come up in the journals, and then you have this low sensitivity. It's not recommended as a screening test in then asymptomatic women. That's one thing which we'll have to understand. Then we add up HER. What is that HER? It's a human epididymis protein 4 that is called HE4. We add it up to CA-125 to make it as a Roma test. And that is improved, but it is improved for understanding the recurrent conditions and the progression, but not as a screen. So has HE4, this question always comes up, has it, taken the place of CA-124? So what is the position of HE4 as a biomarker for ovarian cancer? It detects ovarian cancer with a 67% sensitivity and a specificity of 96%. Therefore, the false positivity is lower as compared to CA-125. It can also differentiate between a benign and a tumor, the cancer, and elevated is it is expressed, early stage. So in an early stage, you see 5 to 8 months prior to the relapse also. So it is very nicely, utilized for understanding the progression or the recurrence of the disease. So it is in concurrent settings, definitely it does have a significantly higher thing. Now, once you talk about these things, you further go to understanding of sonography, because again, sonography is a very beautiful parameter to understand our ovarian this thing. So what is a morphological index which we are using for understanding ovarian status? We have a 0, 1, 2, 3, 4, 5. This is nicely done by the paper in Depreste has come up with. So you have a cyst wall structure, tumor volume, septum structure, and a morphological score of 5, which is used when you are using RMI. When you are using RMI, you have a sonographic score having all these parameters, like whether it is unilocular or multilocular, whether there is any metastasis, ascites, bilateral involvement. Then MS for menopausal and CA-125 score. If it is above 75%, the risk is 75% when RMI score is above 250. Then another thing has come up is ROCA. Now, the United Kingdom Collaborative Trial of Ovarian Cancer Screening, a randomized control trial was done for 2 lakh women, and they came up with the risk of ovarian cancer algorithm ROCA. Now, that is the position for, that's the paper from where I have taken up this, that eligibility of ROCA is it is done for postmenopausal and over 50 years of age. And between 35 to 85 years, it is been done, and for it mainly it was used for also the familial cancer conditions and Lynch syndrome also. So what was the outcome of all this was it's a high sensitivity with a high specificity and good PPV, and the PPV value is a little bit of less, but then of course it has got a high sensitivity and specificity. So the diagnostic, why are we using all these tests, is to identify between a benign and a malignant, how to go, how to do the management. So most are benign, most of the ovarian masses are benign, whereas in the postmenopausal age, it is 60%. Now, therefore, you have to have a combined multi-institutional things to understand ovarian. Now, after talking about from ovarian, I'm jumping straight to endometrium. Now, endometrial cancers, you know the risk factors for the endometrial cancers. If I have to put it more categorically, you have this as a premenopausal woman and a postmenopausal woman. Look at the risk factors: endogenous estrogen exposure, anovulatory cycles, PCOS, morbid obesity, estrogen secreting tumors, and hereditary conditions. And in the post-menopausal woman, again, morbid, estrogen secreting, exogenous conditions. Then you have estrogens are given without progesterone, tamoxifen use, pelvic radiations, and hereditary syndrome. Now, what are the screening? Screening usually is with this thing, transvaginal sonography, where we have 5 mm. These are the parameters which has been set at an endometrial thickness of less than 5 mm in a symptomatic women would indicate 1% chance of endometrial cancer compared to 10% in the general population. So whenever we are doing thickness and whenever we are putting a formal hysteroscopy, office hysteroscopy, you say, and you're trying to do an endometrial curettage, most of the time, 65% of the endometrial cavity is sampled. And now, whenever you're using for a TAMO, you have to have this history very clearly, because that gives a very high false positive rates if you're using a tamoxifen. What is the American guidelines? Cancer Society recommendations are asymptomatic women who have Lynch syndrome or a history of colon cancer, they have to go for an annually for endometrial biopsy beginning at the age of 35. Of course, progesterone has to be added to estrogen and HRT, and women undergoing surgery for colorectal cancer who do not wish to preserve a fertility can be offered prophylactic hysterectomy and or oophorectomy. A little bit of touching and going the Lynch syndrome. People have been talking so much about Lynch syndrome these days. It is nothing but it's an autosomal dominant inherited syndrome. It's mainly caused by germline mutations and DNA mismatch repair. And you have that whenever there's a mutation, carriers have an increased lifetime risk of developing colorectal cancer, which is to the 40 to 80%, endometrial cancer 33 to 61%, and ovarian cancer 9 to 12%. So in such conditions, it is always better to have done the screening in a very early age, and also preferred for oophorectomy and the prophylactic hysterectomy. Recommendations for screening has been asymptomatic patients, no risk factors, and abnormal physical examination. You routinely follow yearly. If there is an increased risk, you will do a transvaginal every yearly, and then tamoxifen use, annual sonohistogram, genetic risk factor, do an annual endometrial biopsy, abnormal physical examination, do a transvaginal ultrasound. If it is a symptomatic patient, of course, office hysteroscopy, endometrial biopsy, and a transvaginal ultrasound with a DNC is better. So thank you very much. I think I didn't over exceed my time. Thank you very much for patient hearing.